Hello guys, in this discussion we're going to look at peptic ulcer disease. But before I proceed, I'd like us to remind ourselves of our previous discussion on gastritis, where we said one of the consequences of persistent or chronic gastritis would be ulceration, which is basically loss of the mucosal layer due to persistent damage to the mucosa. With that being said, peptic ulcer disease would therefore be defined as a solitary mucosal ulcer which can involve the proximal duodenum in about 90% of cases or the distal stomach in about 10% of cases. Before I proceed to the individual types of peptic ulcer disease, which is duodenal ulcer and gastric ulcer, the other thing that I would like to mention is that you will notice that causes or rather risk factors that lead to duodenal ulcer or gastric ulcers are those risk factors which have been talked about under the discussion on gastritis. Because of that, in this discussion, we want to discuss risk factors in details on how they lead to gastritis and perhaps later on to ulceration, because that has already been done under the gastritis discussion. So I would advise, if you haven't seen the discussion on gastritis, you first start with the discussion on gastritis, then proceed to this discussion, which will help you to connect things easily. Okay, so we proceed with the duodenal ulcer as a type of peptic ulcer disease. So in duodenal ulcer, this usually occurs due to H. pylori, and in rare cases it may be due to Zollinger-Ellison syndrome, and these have already been discussed under gastritis. So the classical presentation is epigastric pain that improves with meals, or epigastric pain which is alleviated with meals. Diagnosis by endoscopic biopsy will show an ulcer with hypertrophy of Brenner glands. So these Brenner glands are glands that are found within the duodenal mucosa, and they secrete a mucus-like substance that help to prevent ulceration within the duodenum. In cases of rupture of duodenal ulcers, if the ulcer was located posteriorly, of which anterior ulcerations are common, but in cases of a posterior ulcer, rupture would lead to bleeding from the gastroduodenal artery and may also lead to acute pancreatitis due to leakage of gastric substances onto the pancreas, leading to irritation and later on acute pancreatitis. When we come to gastric ulcers, which are also a type of peptic ulcer disease, these also usually occur due to H. pylori, but other causes would be NSAIDs and bowel reflux. The classical presentation with gastric ulcers is epigastric pain that worsens with meals. A meal will stimulate the production of hydrochloric acid. Hydrochloric acid will then cause irritation and worsens the pain. Yeah. So the ulcer in this type of ulcer, which is gastric ulcers, will usually be located in the lesser curvature of the antrum. Here I like making it easy to understand by reflecting on the fact that when we talked of chronic gastritis, we said one of the types of chronic gastritis is H. pylori gastritis, and H. pylori gastritis usually involves the antrum. And because we already understand it to say H. pylori is the commonest cause of gastric ulcer as well, so it is no surprise that this ulceration occurs in the lesser curvature of the antrum. So that's how I like connecting the dots on this one. Yeah. Well, in cases of rupture in gastric ulcers, this carries a risk of bleeding from left gastric artery. That might also be important to make mention. Now, when you understand that, before I move on to the last aspect, one thing that I would like you to understand is that The way epigastric pain is associated with meals is different in duodenal ulcers and gastric ulcers, and that is very important to take note because it is one of the questions that we ask in patients when we suspect peptic ulcer disease. Does the pain worsen with meals? Is the pain alleviated with meals? So remember that in duodenal ulcers, the pain, the epigastric pain, will improve with meals. The way I like to think of this one is you have ingested some food substances. So as they leave the stomach to enter the duodenum prepares itself to receive the acid containing substances by secreting substances that will help to neutralize the acid. Of course, even the pancreatic juices which and the bile salts which contain bicarbonate ions will help in terms of trying to neutralize the acid content that are coming from the stomach into the duodenum. So those neutralizing substances will also have a cooling effect on the ulcer, thereby relieving the pain with meals. So that's in duodenal ulcer. The epigastric pain is improved with meals or alleviated with meals. In gastric ulcers, the pain is worsened with a meal because the gastric ulcer, the ulcer is located within the stomach itself. So a meal will stimulate acid production, and acid will further cause irritation on the already existing ulcer, worsening the pain, or rather stimulating the pain itself. Okay, so that's an important aspect to take note of. Okay, so now we move on to the other part. The other part that I want to mention is that when you talk of peptic ulcer disease, or when you think of gastric ulcers or duodenal ulcers, remember that the differential diagnosis is gastric carcinoma. When we talked about the diagnostic procedures under gastritis, we mentioned to say endoscopic biopsy is one of the gold standard because it will help differentiate a benign ulcer from a malignant ulcer that might be due to gastric carcinoma, specifically of the intestinal type which presents with ulceration. Okay, so meaning it is important to understand that where you have gastric ulcers, you must have you must know at the back of your mind that a differential diagnosis can be gastric carcinoma. Okay, and endoscopic biopsy is what will help to differentiate the two. So with that being said, I'd just like to highlight the following points where you just have to know that duodenal ulcers are almost never malignant, and gastric ulcers can be caused by gastric carcinomas. You get that point? Gastric ulcers can be caused by gastric carcinomas. Therefore, when you have a case of gastric ulcers, your differential diagnosis should be gastric carcinoma, because it can also cause gastric ulcers. The last point that I would like to bring out before we conclude this discussion is that in cases of benign ulcer and malignant ulcer, via endoscopy and imaging, what you would basically see is that a malignant ulcer would show more of a large ulcer which is irregular and it has raised margins or hipped up margins. But a benign ulcer would show you a small ulceration that is more of a punched out ulcer. Yeah, so it appears like a punched out ulcer, and it has no raised margins or hipped up margins. Yeah, so that's again one of the ways you can differentiate these things. Okay, so that was it. That was our discussion on peptic ulcer disease in association with gastritis, which would later on lead to the same ulceration. Okay, so I hope you find this helpful, because we've now come to the conclusion of the discussion. Thank you for your time. Have a blessed day.